So I'm beginning with the case history. The child was an 11-year-old boy. He presented to us with a prior history of left nephrouretectomy in January 2019 of an 18 by 16 centimeter mass in the left renal fossa. The histology had come out to be triphasic Wilms tumor with favorable histology, and lymph nodes were negative. The adjuvant chemotherapy given at that time was a two-drug regimen, EA4A regimen, given for 18 weeks. And the follow-up CT scans, there were 2 follow-up CT scans that were done, which were reported as normal in August 2019 and February 2020. The child presented to us in July 2020 with an epigastric swelling and pain since 1 month. And on examination, we found a hepatomegaly with 18 centimeter liver below the costal margin, reaching even up to the umbilicus. The CT scan done showed 3 nodules, a 7 by 9 centimeter mass, a 6 by 7 centimeter mass, and a 3 by 2 centimeter mass in the segment 6, 7, 4A, and 4B of the liver. There was also a mass in the left renal fossa of 4 by 3 centimeter infiltrating the psoas with multiple retroperitoneal lymph nodes. There was a nodular lesion in the superior segment of the right lower lobe of the lung as well. So a diagnosis of recurrent Wilms tumor of local liver and lung mets was made. So the questions that arose here were, is a biopsy required in this case? If yes, then where should the biopsy be taken from, whether from the liver, from the local, or the lung? So a core needle biopsy from the liver mass was done, as they were easily accessible. So which showed a Wilms tumor with mostly blastemal component, and which was WT1 positive on IHC. So what should be the further management with this biopsy in hand, whether it should be surgical resection, chemotherapy, or something else?
Okay, so I would recommend, well, it depends a little bit, again, on the initial histology. The relapse regimen is recommended with ice. And what could be considered also would be a 3-drug regimen, including doxorubicin, vincristine, actinomycin D, and doxorubicin. So if there was good response from the initial tumor, I would first apply this. And if there's no good response of the relapse, I would change to ice. If there was no good response of the initial tumor initially, I would immediately start with ice.
I hope everybody agrees with this. So we'll move to next. Anybody looking for upfront resection after this?
No, not for relapse. No way.
Okay, thank you. Dr. Tanvi, you get
Sir, yes, sir. So we did not know the exact outcome of the initial chemotherapy. So we proceeded with the initial plan that sir had suggested, that we proceeded to give doxorubicin as well as vincristine and actinomycin D, that is the DD4A regime. That was given, and then a reassessment was done at 6 weeks. Following this, that there was not much response, as we can see from the November CCT scan showed here. And there were persistent mets in the liver, local, and lungs. So what should be the further management after this? Whether we should give an alternative chemotherapy? If yes, what regime? If no, then should we proceed to surgical resection or radiation therapy?
Sir, Dr. Sajid.
This seems a little weird with doxorubicin challenge also. There is no response. Are we certain about the histology? Okay, so it is a blastomal predominant type of relapse. Now this blastomal predominant is...
It was initially a triphasic Wilms tumor.
It was initial triphasic. So I'm not able to place the significance of the blastomal in this situation. The relapse, now is this to be taken as a blastomal type post chemotherapy, or it is inherent some bad histology itself? So in any case, if it is a bad histology, if we assume that this is a bad histology, which is it's depicting itself also with no response, then this is a time for a serious reassessment for first surgery. And then if we don't have, if we are not very certain, or if there is a small chance that we might get something from the histology, maybe there would be a small role for some escalation of chemotherapy to cyclophosphamide and etoposide. Steve, what's your thought on this?
What makes it a little bit difficult for us, because we are living in a situation where we have neoadjuvant chemotherapy first. So we know what the initial tumor reaction was like. And because in this type here, we are not certain whether when we see blastema in the relapse, we are not sure whether there's really a change in the histology from the primary tumor to the relapse. If that would be the case, then certainly a more aggressive chemotherapy would be the first choice in my view. In this, anyway, you have problem locally, you have problem in the liver and in the lungs. And before you tend to local treatment, such as surgery, for example, you want to have any type of response of the tumor. You want to see that the tumor is responding because you're dealing with a systemical problem. And as long as the systemical problem is not under control, you will find difficulties to answer with a local answer. So I would go and opt for intensification and change of chemotherapy. ICE would be the first choice in this case. And then I would make an early reassessment. I found that when you presented that you waited 6 weeks to evaluate the 3-drug regimen, that was already a little bit long in my view. I would have preferred an earlier reassessment and an earlier change. So I would administer ICE, but not wait too long to reassess and then take the next decision.
Thank you, Dr. Steve. Dr. Yogesh Sarin has joined us. So he will like to comment.
Yeah, I totally agree with Dr. Warman. I mean, whether neoadjuvant or not, I mean, this is now the histopathology which has come after the chemotherapy has been instituted. So it's a bad blastomal cells and must be given ICE. And I will still feel that maybe reassessment at 6 weeks. I mean, Warman probably is suggesting reassessment 4 weeks after ICE. I would still say 6 weeks of ICE and then reassess whether we could resect or not.
Thank you, sir. Now we see.
So we'll proceed.
We proceed with Dr. Tanvi did next. You're not audible. Unmute, please. Unmute, please, Dr. Tanvi.
So am
Yeah.
I audible now? Sir?
Now audible, yeah.
Sir,
Is the screen visible?
Yes, sir.
Sir, our treating unit, our medical oncology unit collaboration proceeded with the ICE regimen that was given 3 weekly for 4 courses. And after that, a reassessment was done, which showed a partial response in the liver mets as well as the loop and the lung mets.
Next. Next.
Next.
So what should be the further management in this case? Whether there should be surgical resection? If yes, then which should be handled first, the abdomen or the lungs? Or there should be further chemotherapy that should be given? If yes, then what regime?
We'll go with the Dr. Steve.
What's the situation in the lungs? You said partial response. How many mets and how big are they in the lungs?
So there was a single metastatic nodule in the lung, which was present in the superior segment of the left lower lobe. Left lower. Okay. So I would go ahead with single stage procedure. I would suggest to do hepatectomy now with resection of the left-sided lymph node. And depending on how well the child is after this, I would either go ahead in the same anesthesia to resect the metastasis or to come back a couple of days later. We have experience with labeling of lung mets and resecting them after CT-guided labeling, and this can even be done thoracoscopically. So if that's possible in a single lung case as in yours,
that could be done upfront. So in this case, if this would be amenable for labeling, I would do thoracoscopy first and then go ahead with the abdomen. This would depend on the site of the lung met.
Dr. Sajid?
Would agree to what Steve has said. The lung seems not to be a problem, but the liver, I think, it was something in the segment 4 also.
Yes, sir.
Yes, sir.
So it is going to be a extended resection, and so it has to be taken planned really well, because this is a major surgery for a metastatic disease. You should be able to take care of the local disease if at all it is there, and the lymph node. And we have to have a good we should have a complete excision, and the extent of that resection should be decided very well.
Dr. Sarin, if you have a difference of opinion, you can comment. Otherwise, we can move ahead to the next what they did.
That when I'm going through the abdomen, I can go transdiaphragmatically and excise the nodule as well.
Side was made.
Thank you, sir. Dr. Tanvi?
Sir.
Yes, please go ahead. What you did next?
A plan by the treating unit was made to go for a 2-stage procedure. First, to handle the liver and the local recurrence, and then go for the pulmonary metastatectomy. So the child underwent extended right hepatectomy and resection of the local recurrence within the left psoas muscle. There were 3 masses in the liver and 1 in the left psoas and renal fossa, with multiple small retroperitoneal lymph nodes. The histology came out to be Wilms tumor, mostly epithelial with no blastemal component, both in the liver and the local recurrence. So what should be the further management for this case? Should the pulmonary recurrence be resected first, or additional chemotherapy should be given? And pulmonary RT, should it be given first and then resection of any residual pulmonary nodule? Whether there is any role of abdominal radiotherapy and when, and whether there is any role of pulmonary radiotherapy or hepatic radiotherapy.
Dr. Steve?
So that's the point that I was mentioning. If we do this all in one, if we had done the lungs by now, we would have now to deal with a question of chemotherapy, radiotherapy, and so on. Now we are still having a surgical problem, and we are facing this in terms of the complete course of the child. So again, I would opt to do the surgery, if it's possible, as soon as possible. And if we can do it very quickly, then we would not have a large time until chemotherapy. If the child is not recovering well from the surgery that has been done, then I'm afraid we have to put another course of chemotherapy in between. And then I would stick to ice, because we saw a response to it. And then I would go ahead with surgery after ice. Concerning radiotherapy, if we have no sign for blastemal components, I would be reluctant at this stage to apply radiotherapy. I would rather go back to the pathologist and ask him what he told us about the predominant blastemal compound in the biopsy that he has taken from the liver.
I hope there is no differences of opinion from other experts. So
Dr. Jindal?
Sir.
Can I interview? Yeah, so actually the plan was to go ahead with the pulmonary resection within a week of the hepatic resection. Unfortunately, child developed a biliary leak and is still in the ward. Is 2 weeks down the line, and we are trying to cope up with the biliary leak and hope that we can get on with the pulmonary resection as soon as possible. So after the pulmonary resection, we plan to go ahead with another 3 courses of ice to complete the chemotherapy regimen, and then have a discussion with the radiotherapist if radiotherapy is required. I agree with Steve that if it was all epithelial and no blastemal, then I would be really hesitant to give the radiotherapy to the residual liver. The question of giving radiotherapy to the whole abdomen will still remain.
The biopsy came from early, sir.
Is that okay, Steve?
Yeah, that will be fine. That will be fine. It's interesting because
I can't hear you, Steve.
We also had some cases in which we found only
Dr. Jindal,
can you hear me,
Steve?
Okay, we are audible to hear, sir.
Yeah, okay.
You can, okay. So I was just saying that sometimes the epithelial predominant tumors are also not very well responding, and this seems to be a case here. So this is something that we also registered. But on the other side, I think it's clear forward to go from here. What I mentioned with the labeling of the tumor in the lung, we have a system in which we put coils that are attached to a wire, and this wire comes out of the lung, and you can be able to identify the coil and resect it thoracoscopically. So you can do this in the same anesthesia as you do the liver resection, and then the child has not much morbidity from that, and you are done with anything that goes with advanced surgery.
What was the biopsy finally, sir? Dr. Sandeep?
Yeah, the biopsy is for this child is mostly epithelial. The lymph nodes are negative. The liver mets and the local recurrence both had epithelial, no blastomal elements. WT1 positive, but no blastomal elements.
Right.
May I ask a question, please? We have had patients who have been having multiple recurrences after whatever you have done with epithelial Wilms tumor. So it's a problem.
Steve and Sandeep sir, in a recurrent setting, irrespective of the histology, how confident or how comfortable you are in leaving the patient after the local treatment without radiation? Be it epithelial or whatever, it's a recurrent disease, and recurrence loco-regional plus metastatic. So, and radiation naive, it was a stage 1, stage 2 disease.
Yes.
So how comfortable are we in leaving the child without loco-regional radiation?
So it's a very good question, and we have given radiation therapy to all our recurrences, be it in the lung or liver, or especially for radiation naive patients. So this patient has not had radiation. I think I would still prefer to have him radiated both in the liver and the lungs after we complete the surgical therapy. We'll have to discuss with our radiation oncologist. Steve, what do you think?
Yeah, no, it must be clear. Radiation therapy is part of the treatment plan for relapses. There's no question about it.
Okay.
In this case here, what makes me a little bit reluctant is the fact that we did not have neoadjuvant chemo. So we still do not know what the response would have been to chemo of the primary tumor. And then we had this a little bit difficult situation with the blastema, no blastema. Now we don't find blastema. And this again is something that makes me a little bit curious about this initial histology and the histology now. So in the end, it occurs to me that we do not have a blastema predominant tumor. So the aggressiveness to go ahead is certainly something that is to be considered now. So my question to the pathologist would be, how vital is the tumor now? How vital are the relapses in the liver, locally, and in the lung? And then discuss with radiotherapists. That is just because we had these little irregularities concerning histology. In principle, of course, radiotherapy is within the plan of relapses.
I have one question, sir. Suppose in relapse, we are initially given actinomycin and vincristine, and we started with adriamycin-based chemotherapy. So after how many doses of adriamycin we say that there is no response to adriamycin? Minimum how many doses of adriamycin we should get?
Do you mean neoadjuvant or after surgery?
Neoadjuvant.
Neoadjuvant, you apply this for 4 weeks.
4 weeks.
Yeah, 4 weeks, and then you have your reconsideration.
And if there is no response, we'll go to ICE.
No. In the neoadjuvant setting is different from the relapse setting.
In the relapse setting, I'm asking. Suppose there is a relapse, and initially in the initial therapy he received AV.
If you have no response initially,
Yeah.
And then you would be thinking about adding doxorubicin as third medicament before operation.
Yeah.
And then you go ahead with operation. And in case of relapse, if you do not have response to neoadjuvant chemotherapy, you immediately start with ice.
And how many days of dose of ice we should check that there is a response or no response? Then only we go for surgery.
4 weeks.
4 weeks.
And then if it's responding, you make the decision of whether you go ahead. If you have partial response, if there's no response at all, you're again thinking about changing or you're in trouble.
Yeah, if there is no response, we any other options except for going for surgery?
Yeah, the last option would be carboplatin VP16. But this is something we always discuss this with our tumor board, our national tumor board then, because this is really a tough question. If you have no response if you have no response of the relapse, then another question would be to perform another biopsy to see whether there's anaplasia or stromal predominant subtypes, because those also would not respond to chemo. And then from the same biopsy, we would monitor whether there is molecular targets in order to be able to perform any type of targeted treatment. But if the ice treatment is not responding, then you're in trouble. But usually there is some kind of response to ice.
I had a case of recurrent Wilms tumor that initially received the primary therapy actinomycin vincristine. Then following recurrence, we gave a adriamycin-based therapy. It didn't respond. Then we moved to ice. It didn't respond. So finally, I went ahead and did surgery. And after that, we came out as again the stromal predominant.
Yeah.
And finally, that lymph nodes were positive. We gave radiotherapy. It's doing well.
Yeah. Yeah.
So,
but certainly this would be very unusual for the case that you presented here, because here you have relapse in the liver and lung and locally, and this most likely is not stromal predominant then.
Yes, sir.
Vivek, we should move to the next case.
Yes, sir. Thank you, sir.